Stellenbosch in the Netherlands. My name is Pascal Morasira and I welcome you to today's liftoff event for GOR3. Did you know that every 10 seconds a child born in low and middle income countries dies from complications that are curable only if they were treated on time? That is 3 million children every year. Myself growing up in rural Rwanda, it was fairly common to hear stories of babies dying in such unfortunate circumstances. However, when I was grown up, I got a chance to work for one of the most exciting projects I've ever worked in my life, which was setting up Africa's first end-to-end digital healthcare service operating at national scale. During this period, I really realized how much information communication technologies can help democratize access to healthcare, irrespective of where you're born or your socioeconomic status. Now, today is a special day. We're going to have an interesting conversation with a group of Dutch scientists, engineers, and healthcare professionals who have come together to work on a truly revolutionary technology. In the next 2 hours, we will have a very interactive conversation, and we will hear the stories, the inspiration behind this idea. Actually, we'll also listen to the presentation and the demonstration of the technology itself. We will also hear how this technology can reach you in your healthcare facility or wherever you are located in the world. Without further delay, I would like to invite the CEO of GOR3, Nick Versteegt. And he is going to tell us in short, why did you start GOR3? So what's the story behind GOR3? Nick, the floor is yours.
Okay. Thank you very much, Pascal, for introducing me and taking this word and for being here today. And while thanking you, I would also like to thank everybody who's sitting at home or at his work or her work watching us today. So about myself, my name is Nick Versteegt. I'm a tropical doctor and a specialist in family medicine. I'm very happy to be here as the CEO. And today, we would like to take you along in our story, in our GOR3 story. Me, myself, the team, and everybody. And why do we want to go that? I think it all boils down to one saying: if you want to go fast, go alone. If you want to go far, go together. And this is, in a way, an invitation for everybody in the world to join us in our mission. And we will explain about who we are, why we think we need to be there, and what we're going to address. And for myself personally, this journey towards here started almost 10 years ago when I did my final rotation as part of my training as an MD in this hospital you see in the picture. This is the Sengerema Hospital in the north of Tanzania, where the healthcare of underserved people really got to me. And after I returned from there, I trained as a specialist in tropical medicine and international health. And together with friends, I erected a foundation to support this hospital. And in 2015, I returned to this hospital with a lot more baggage, both financially from the foundation and a lot more knowledge and skills at that stage. And one of the main things I did there was a combination of projects and clinical duties. And one of the projects I knew I would be doing was trying to improve the neonatal care, because we knew this was a big problem, and neonatal care is actually a big problem worldwide, of course. And this was the situation there at that stage when I came there first, that 3 babies were sharing something less than a desk, were sharing 1 oxygen concentrator, and were sharing 1 light bulb to actually thrive. And these were critically ill children, so it was a real challenge. And that's why we decided that with our foundation and with the hospital and with local government to start a project around neonatal care. And one aspect was that, of course, training healthcare professionals in the resuscitation of neonates directly after birth to make sure that they can breathe well, that they recover. And the other aspect was the erection of a neonatal intensive care department. And this was a big success, actually. We got support from the government, the hospital, we got a great team, and it's actually a success up until today, because every year there are 1,500 children who are admitted to this ward, and mortality has dropped significantly. And one of the most amazing experiences I had at that time was that one of the kids, the one you see here in the picture, he was named after me, and his parents called him Nick Mandela, and that was really funny, but it also felt really rewarding. This boy was premature, he survived sepsis, and he survived because of his improved quality of care. And this is a story I like to share, but what I usually don't tell is how difficult that period was for me, because I was living apart from my wife, and this was really a beacon of hope at that stage, because I was overworked. I was really trying to keep afloat in a busy hospital with a lot of pressure to perform, and there were many more patients that I could take care of. And this patient was special because it was the baby of a relative of one of the nurses. And she texted me, and I walked by there 2 or 3 times a day, even in weekends, to make sure this boy survived, and that was important to me. And that is something we usually don't realize, and what we don't like to tell about how challenging this situation is, because how do you keep oversight over so many babies? There were more than 30 babies. There's one nurse taking care of more than 30 babies at that stage. And there are a lot of places where it's worse than this. And there's a lot of places where the quality of care is lower than this. And that's a challenge. And for me, I'm just a bypasser. I was there for 6 months. I'm not living there. I don't have to do it day by day. But this is a real challenge, that these health systems are overburdened. And there's really a global problem, because there are more than 6 million children dying every year due to conditions which are largely treatable or preventable, or both. And the total number of deaths that are preventable and occurring every year is 15 million. And every year, more than 100 million people are driven into poverty due to health-related consequences, either because they cannot work or due to high costs or other combinations of it. And what is really staggering is that more than half of the world's population does not have access to essential health services. That's more than half, and that's undermines societies. We have all seen during the corona crisis how healthcare can be the backbone of societies, and societies come to a standstill when the health system is under pressure. And this is something happening every day there. And it prevents progress, and it prevents building of societies. In Africa alone, it is estimated that 2 trillion euros are lost due to health-related consequences, which are largely preventable. And if there's one thing that I've learned as a doctor in the Netherlands or in Africa or wherever I've been, it's that we all health. And we all health is our Goal 3 slogan. And for me, it means we're all equal. Everybody has the right to healthcare. And how can this open wound be there, that all these children, all these people are dying for nothing from conditions which can be treated for less than €1? And that's why we say it's time for change. We need to address this, and we need to work on this. And that's something that is acknowledged broadly by a lot of people. And the United Nations have set 17 goals for 2030 to change the world for the better. And one goal is dedicated to healthcare. And that's good health and well-being, the third goal. And of course, that's where our name originates from. And it's part of our ideology, but mostly also about our ambition, where we want to go. Because in 2030, we want to have global impact on healthcare and make sure that more people have access to healthcare. And The way we're going to do it is, of course, with smart technology, and that is something we see all around us, and that's all over the world. We see people who are digitalizing, and we see opportunities that were never there before. And I was happy enough to meet very smart people. So when I met Bart, my co-founder, we immediately found each other, and we wanted to address this together. And that's where we originate from. And our reason of existence is the people who are underserved. So we'll be doing it for places where it's needed most, because that is where we need to change. And our focus currently is on Eastern Africa, but we'll be conquering the world if we are able to, because that is what is needed. And it will not be our solution for them. It's something that we need to create together. We need to find these solutions together. We're not the ones who can think of everything that is needed, and this is something that is core to how we think. Everybody should be part of it. And we believe in collaboration and not competition. It should be, let's create this together. There are 4 billion people underserved. There are so many people desperately needing healthcare. So why would we focus on competition? Let's address this together, and we actively seek for collaborations in this perspective. And I'm very happy that within almost a year, we have now grown out to a team of 10 people, international even, because we have Martin Marcheria, who's actually a Kenyan developer, has joined us recently as well. I'm really proud of that, and I think we can achieve this together. At Goal3, we have a vision. We believe in fair and accessible healthcare for everyone. And because we strongly believe that health workers are the key to achieve that they are the most important people to bring this to the people that need it, our mission is to enable and empower health workers, because we think they can bring the care their patients need and deserve. And we have set a goal. We want to improve the access to care for 100 million people by 2030. And the only reason it's not 1 billion or 4 billion is because people will not believe me when I tell that I want to do that before 2030. But that's what our real ambition is. But this is our minimum, and that's what we'll fight for to achieve. And that is why we're here today, to share this story and take you along, and to tell you about how we think we can get there. And from there, the rest of this day, my team and other experts will explain you what we'll be doing and how this will work. Thank you all.
Thank you, Nick. This is a very inspirational presentation. But I'm sure in the audience we have people who have questions. And I would like to remind you, if you are following this presentation, this event today, you also have an opportunity to ask questions, either by raising your hand in the Zoom meeting, or by typing in the comments in the YouTube live stream. But before we move to that Q&A, I would like to also ask our participants if they can also pay attention to the following video. It's a video that explains this challenge you just talked about, but from the Malawian perspective. So you told us the story from from Tanzania, and comparing in the Netherlands here where you are a practitioner. But let's hear from another fellow doctor, but this time from Malawi. Yeah, can we have the video?
My name is Mai Nguruwe. I'm a pediatric intensive care unit nurse, called a PICU nurse. Currently I'm working at Mercy James ICU.
So the video is live now.
I'm a pediatric intensive care unit nurse, called a PICU nurse. Currently I'm working at Mercy James ICU. I've been working there now for 3 years, since it started up to date. I became a nurse because it was my passion to care, and for me to be specifically interested in pediatric ICU, because it was the first of its kind in Malawi. So I was more interested to take care of, to provide care that is of a higher level, because previously there was a challenge that we could not take care of children on their own. We could just be mixing them. We could be taking care of them together with the adults, but there was nothing specific about children. So it was more interesting to get to know how to take care of the kids, especially the critically ill ones. It's very unpredictable in ICU. You could start with a good day, but end up being a hectic day, because you can have any patient who can turn into a critical patient at any time. Your patient can be recovering very well, and then their condition can just change anytime. So you can go from a stable work day, a nice and calm day, to a very busy day. So when you're just coming to work during your shift, you just have to be prepared for anything. So I could say it's quite unpredictable in ICU. The patient monitors, they help us. It reduces our workload in a way that some of the other things that we're supposed to do manually, it's just the monitor that does it. But we don't leave it all up to the monitor, of course, but then at that point, it still reduces our workload. And it also helps in keeping information of the patient. Sometimes there might be an alarm. Maybe you couldn't be sure when exactly something happened, but if you go in the monitor and check what has happened, it gives a record of that, of what happened. There are some other challenges with the patient monitors. You could find that they could be faulty at some time. So maybe you just want to take a BP reading and then the reading doesn't come, and it takes some time for them to fix it so that it can give the reading. And also some data, like for example, the patient has stayed for maybe 2 weeks or 1 week. It's very difficult to find data from the previous days. There is need for that data to be consistently there. Anytime that you want to see about the patient, you should be able to access that data.
Yeah, this video was about a perspective from a Malawian doctor. And after this video, we are going to follow a presentation from Job. He is from the university, he's from Amsterdam UMC. It's one of the biggest medical centers we have here in Netherlands. Please, Job, the floor is yours.
Not only a pediatrician, so not only a doctor taking care of children, but also a doctor with intensive care experience. And over the past 20 years, I've worked 3 times in Malawi, once at a small district hospital similar to NIC, once at a larger academic hospital, and more recently I started a pediatric intensive care unit in Malawi. This is quite special because it's the first public pediatric intensive care unit in this part of the world. And Moi, the nurse you just saw in the video, was also working in my unit. So for the ones that don't know Malawi, Malawi is one of the smaller countries in Southeast Africa. The inhabitants, the population is roughly 70 million, so similar to the Dutch environment, if you are familiar with the Dutch country population. And within that country in the south, there is an academic hospital called Queen Elizabeth Central Hospital. And one of the largest departments of that hospital is actually the pediatric department. On average, there are roughly 300 inpatients. We have about 12,000 admissions per year. And I've been going to handovers very regularly over the past 20 years, and roughly every day, 5 children die in that hospital, and half of those deaths are preventable, so it could be avoided. So my pediatric intensive care department has 6 beds and looks very nice, very clean. We have well-educated nurses and with quite some facilities. And I learned in that pediatric intensive care department that if you want to make a difference, you have to stop a disease. And if you look at the natural cause of most diseases, serious diseases, then a child or an adult can quite rapidly deteriorate from a very healthy state to a state where actually somebody dies. And of course, we as doctors and nurses would like to prevent that. So if you at an early stage recognize that somebody is sick and give the right treatment, you actually may be able to restore somebody's health and people live happily ever after. I also noticed at the pediatric intensive care department that if you recognize that somebody is sick, but you recognize it at a very late point, you may actually be able to delay the outcome, but you will not make a change. The child will die even with all the best efforts you have, with all the facilities you have in pediatric intensive care, you will not be able to save that patient. So in other words, there is a sort of a window of opportunity, and that window of opportunity is really quite critical because if you miss that window of opportunity, you will not be able to save your patients. And sometimes we get a lot of windows of opportunities. We as parents, patients, doctors, nurses, but sometimes there is only one window of opportunity, and it's all about getting the right diagnosis within that window of opportunity. Just as an example, if you think of maybe infections and bacterial infections, if you recognize an hour earlier that the child is having a severe infection, you will be able to reduce the mortality by 10%. And in adults, that may sound very clear because an adult can talk to you and can verbalize that he's very sick. But in a child, often the patient, the parents, they rely upon the quality of the nurse and doctors there. There's one patient there and we have a monitor. So there is close observation. But Nick also mentioned that in real life, in most African hospitals, there's only one nurse and maybe she's taking care of 20 to 50 patients at a time. And you can already tell from this picture, it will be very difficult if one of these babies is deteriorating to, at the right time, detect something is going wrong. And often this is also mentioned in handover in the mornings. The patient stopped breathing, and we try to resuscitate the patient, but we failed. And the reason, of course, is not that the child was very sick at that stage, but probably an hour earlier, we have missed the window of opportunity. So for a long period, I thought this window of opportunity was actually the monitor missing, the monitor helping the nurse taking care of all these patients to pick out at the right time that this child was deteriorating. In my intensive care unit and also in my high care unit, we had those monitors. But I also realized that these monitors, which are developed for Western settings, for high income settings, that they were not actually the solution to the problem. They helped a bit, but they were definitely not the solution. Why not? Well, in general, these monitors are expensive. They cost a couple of thousands of dollars to buy them, and that's quite high if you compare it to healthcare expenditure in most African countries. To operate them is actually quite complex. As you can see, there are a lot of numbers on this monitor already. To attach it and to properly get all the data is quite complex. They're also vulnerable. They often break down. There are lots of conditions that are quite different in African settings. For instance, only the voltage that can fluctuate quite a bit over the day can actually mean that they break down quite easily. They use sensors that are disposable and therefore they are not durable. But most important, I think they alarm very late. They are designed for a high income setting, for a setting where there's doctors and nurses sitting bedside. So if the monitor alarms that something is wrong with the patient, they sort of expect and anticipate that the doctor and the nurse will be able to intervene within 5 minutes or less. And this is just not the situation. So in general, these monitors are not designed for low income settings. Well, if we would design an ideal monitor, what would it look like? It would be a affordable monitor. It would be easy to use. It should be robust. Ideally, you would make use of reusable sensors. And I think ideally, this monitor would not only alarm when something is wrong, but it would also predict when something is going to happen. So it gives the doctor and the nurse ample time to recognize that window of opportunity, to intervene, and to prevent a death or harm to a child. Well, is it worth investing in it? Yes, definitely, I think so. If I only look at the situation in the hospital I worked in, we had about 200 to 400 deaths per year. Sorry, 500 to 800 deaths per year. If we would only be able to prevent 50% of that, that would save already 250 to 400 lives, pediatric lives a year. If I look at Malawi, where half of the population is under the age of 18, we would be able to save 2,500 deaths per year. And if you just think the impact this could have on the world, where 90% of all pediatric admissions actually occur in low income settings, then it could save up to 500,000 or 1,000,000 pediatrics deaths per year. So definitely, I think it's worth investing in Gold3. I think it's worth investing in a smart, affordable, and robust monitor.
Thank you, Job. This is a very interesting presentation. And thank you also for giving a scientific perspective with the figures you just showed to us. This is time for anyone in the audience to ask questions to the previous presenters, so the CEO of Gold3, Nick, and also to Job. But I will open this Q&A session by asking some questions to both our speakers. To start with you, Job, you work for Amsterdam UMC. It's one of the one of the biggest medical centers in the Netherlands, but also in Europe. Out of curiosity, why did you decide to work with Gold3? I'm sure you had many other options. Why Gold3?
Start with you, Job. You work for Amsterdam UMC. It's one of the one of the biggest medical centers in the Netherlands, but also in Europe. Out of curiosity, why did you decide to work with Gold3?
Well, I think definitely.
I'm sure you had many other options. Why Gold3?
Yeah.
Start with you, Job. You work for Amsterdam UMC, one of the one of the biggest medical centers in the Netherlands, also in Europe. Out of curiosity, why did you decide to work with Gold3?
Well, I think definitely.
I'm sure you had many other options. Why Gold3?
Yeah.
Start with you.
So just to answer that, I think definitely Gold3 is not only answering something that is really important, so trying to close a gap, I think a technical gap. So I really believe in the technology, and I also over the last year we've been working together, really started believing in all the capacity and also the motivation of all the individuals that work there. So I do not only believe that we're solving a problem, but I think also we're doing it in the right way.
Thank you. In your opinion, why isn't there a device that meets the characteristics that you just mentioned to us? So you showed us the ideal monitor and the current monitor. Why do you think there is a mismatch with the realities on the field and what the devices that we have available in these healthcare facilities? Question to you, Job.
Yeah, actually, it's a good question, and it's a question I think to the rest of the world. I think so far nobody really has thought of this, putting all these pieces of the puzzle together. I think there are a couple of robust sensors that have been identified and developed by BART. So I think that is one part of the puzzle. But I also think by putting all these smart things together and putting all the technologies together that are there currently, we have made something really new. I think that definitely is an advantage. Why nobody has thought of it? Well, to be honest, I don't really know. I think it's just a great idea, and I believe probably we are the first ones to put all these things together. And by putting all these things together, this is something great, and I think really something we should push for to get out on the market.
Yeah, indeed, in business, timing is everything. Yeah? Now, back to you, Nick. Why do you think Goal 3 is... so you were just starting, you started a year ago. So why do you think your mission is different from any other organizations out there? What makes Goal 3 unique, in your opinion?
It's a very good question, actually, and I think it really started from the need. It started from something I really deeply felt, and I think it was clear just now, but and that's different. It doesn't start from a technology push. It's just starting a social enterprise for us is just a means to achieve our goal. But it starts really with the goal and the ambition, and I think that is something that is quite rare in a lot of enterprises, but luckily not exclusive to Goal 3.
Yeah, I would like to remind our participants that during these Q&A sessions, so they are also free to just ask any question. And if, in case for the sake of time, we don't get to answer all the questions that come in, we will try to answer them after the event, but also hopefully in the following presentations, we'll also be able to provide some insights that are relevant to questions you're having now. Before we move to the next presentation, so we just had we heard your presentation. We had a presentation from Amsterdam Medical Center. Can you tell us, in your opinion or from your perspective, what have you learned from this collaboration with Amsterdam UMC?
Sharing a dream is the best thing you can do, because I think we share the passion for addressing this problem, and it's last year was amazing, actually, because at times no person got paid, nobody thought he was getting a reward of it, and I was texting in Sunday evening at 11 or 12 after midnight, actually, with Job Kalis or Job van Woensel or Bart to really make sure that we meet the deadlines that we need to make to progress our ideas. And with a shared vision, you can get far and you can really achieve things.
Thank you. So we would like to keep you for much longer, but we'll get another opportunity to discuss. But we would like to now move on to the next presentation. Many people in the audience may be wondering, like, yeah, you were talking about monitors, but yeah, or technologies, but what's the technology itself? What is it about? And in the following presentation, we are going to actually learn more about this technology. And this presentation will be given by Bart. He's the CTO of Goal 3 and also a co-founder. Bart has studied industrial design and did many health-related projects, several of them in the neonatal intensive care unit in Veldhoven, that's near Eindhoven here in the Netherlands. But unfortunately, he's not here with us. Well, I can say unfortunately, but also fortunately, because he has been in Malawi conducting live tests of the device with real healthcare professionals in Malawi. He just came back, but due to coronavirus regulations, he cannot be here physically with us. So he will be joining us on Zoom. But if you can hear us, the floor is yours.
Yes, thank you very much. Thank you for this introduction. So, to be clear, I visited Malawi with Job Kalis, the doctor from who just presented. We visited Malawi. For the first time, I saw the PICU in Malawi, where we will test the first product which we are developing. And for this solution, we have 3 core goals for what we want to develop. So the first of all, to make a device which works in the setting, it needs to be durable and affordable, especially in use. Because at this moment, about 50% of the monitoring systems do not work in this context, according to the WHO. And there are many reasons for it. So first of all, it's not durable in the setting because of the humidity, the power spikes, like you already mentioned. In many cases, maintenance is not possible. There are no spare parts. There is maybe not the right technicians or not the right tools to prepare the device. In a lot of cases, people did not get training to actually use the device. So they're not ready to use the device properly and don't know how to solve small issues. And last of all, so our second goal is to provide a better overview of patients in the ward. Because at this moment, like you've already told, there are many patients in the ward, and it's very hard to get an overview of all of them and see what's happening with each of these individual patients. And third, one of our goals is to assist with early diagnosis of deterioration. So what's happening with each of the patients, and can we find which patients are at risk of a critical illness? And more specifically, one of our cases we're looking at is sepsis, for which 1 hour early, detecting it 1 hour earlier would increase 10% or reduce the mortality rate with about 10%. So right now we are developing our first prototype, which we called Impala. So this is where I set it up last week in the high dependency unit in Malawi. This is the device right now. Right now it has all of the standard sensors. So it has ECG. You can see the sensors here right now. It has a battery, of course, in it. It's ready to be used. And to just give a short introduction about all of the sensors which we use, this is a pulse oximeter sensor. You place it on top of your finger, or in case of a baby or neonate, you place it on their foot. And with this, you can monitor the heart rate and the oxygen saturation. These are the ECG electrodes, which you place on your chest with sticky electrodes on 3 places on your chest to monitor the heart rate and the respiration rate. This is a temperature probe, which you place, for example, in the armpits of a patient to continuously monitor temperature. This is the blood pressure cuff right now. So you place this on top of your arm, or in case of a baby or a neonate, you place it on their leg to monitor the blood pressure. But most interestingly, the sensor which I've been working on for the past 3 years is this one. It's placed underneath the bed. It's a very sensitive pressure foil, so if you press on it, you generate a signal. You can monitor the heart rate and the breathing rate with this without any contact with the body. We call this the blissography sensor. And of course, the first thing we did in Malawi was test this with a dog. When I was at home with Job, I wanted to show how it works, and one of the dogs was lying around all day, and I just had it lay down on it, and it actually showed the heart rate and the respiration rate of the dog, which was really cool. But most importantly, we didn't only test it with the dog, but we also did a very small test with a patient which was severely burned. So we placed this foil underneath the mattress and actually got the heart rate and respiration rate with it, which you can see on the right on these graphs. So the top one is the raw data, which you can split into 2 graphs. So one is the respiration rate, and the other one is the heart rate. And what's very important with this sensor is that it's completely reusable, and you can just place it underneath the mattress but can stay for maybe 1 or 2 years. So it will be very durable, even in these, especially in these settings, which is really crucial. So to give clinicians a better overview of their patients, we actually are providing a tablet which has an application to oversee all of the patients at the same time. So you can see, I did a very small user test at the time with one of the nurses to see how they would react if we actually put the device into their hands. And if you click on one of these patients, you get an overview of the trends of the last few hours of the patient. So you can see what's been happening right now in this overview over the last 2 hours, and also see an event, that's where the blue pill comes in, of when the medication was given. And we think that providing this data actually improves the quality of care, because at this moment, for quite a lot of patients, this is not accessible. But that's not where it stops. So, like we have all talked about, is we need to have a window of opportunity to actually diagnose the patient and start treatment. So here you can see two graphs. The one on the top is of a relatively healthy patient. It's still in the hospital, but you can see that the heart rate is going up and down. The histogram looks like a normal distribution, but at the bottom one, the patient has been diagnosed with sepsis later on, and that means that it has blood infection. And you can see that the heart rate looks completely different. So instead of going up and down, you can see that it's actually quite flat, and a lot of deceleration. So a lot of times the heart rate became really low, and which means that also the histogram looks completely different. As you can see here, instead of a normal distribution, it becomes very uneven. So what we want to do with this algorithm is identify which patients are at high risk. So this data, like for example, the heart rate, would provide an indicator of that the patient is at higher risk. And one of the things we aim to do in the end is to give, for example, such a bar as this, like a traffic light, whether a patient is in the green, in the orange, so it needs limited attention, or when it's in the red, when it needs immediate attention. So you can see what's been happening over the last few hours, whether it's deteriorating, improving, or it needs attention at this moment. So to develop our device, we aim to do, or we will start a pilot in 3 months, or in January for 3 months, in which we will co-develop the design with the nurses and the technicians and the doctors in Malawi. I will go there for 3 months, where we do all kinds of sessions like I did already for the past 2 weeks, but then for a longer period of time, and actually go through a whole iteration there. And we will gather data of about 100 patients to develop a first small algorithm, which we hope will show these similar results to, for example, this bar graph which I showed earlier. And the result of this pilot test will be Impala version 2, which we will then use in a bigger study, which we hope to get. So we have applied for a big subsidy, the EDCTP, where we will test our device at 2 sites with the College of Medicine in Malawi and the Research Institute TRU, which are both working together with 2 hospitals in Malawi. And we will work with Polytechnic to improve the technical design. And in the end, we will gather data for 1,000 patients to actually train the algorithm. And in the end, after it has been trained, we'll do a next iteration in which we try to implement the algorithm and see whether this actually improves the outcome of patients. So we will design our system with stakeholders, but right now we're just a small startup and we don't have a lot of experience in the medical device development process, which is why we are working with IDE Group, with Willem Mees, who will give the next presentation to develop the device. And Willem Mees will introduce himself a little bit. He's the director of IDE and is working together with us to get and design a high quality medical device. The floor is yours, Willem Mees.
Thank you very much, Bart. I will share my screen. So yeah, I would like to introduce you a little bit to IDE. We're a team of experienced medical device developers and manufacturers. And what we love to do is build better futures together with people like you guys. And to give you a bit of an understanding of how we do that, I would like to share with you a story of one of the businesses that we've started in the past, and how we built that innovation around a medical innovation. IDE Group was founded in 2003 by two guys in Australia. And since then, we've developed over 250 medical devices. We have offices in Australia, in the Netherlands, and in the United States. And we're now a team of more than 50 expert developers and medical device manufacturers. And we've been building businesses around medical innovations with over 100 organizations now. We're ISO certified for manufacturing and development. And we have these offices here all over the world. So that allows us to manufacture and design with also the network that we have around us in the different parts of the world.
Amazed, we do not see your slides at this moment.
Oh, you can't see the slides? Okay, let me see. Can you see them now?
Yes.
Okay.
Yes.
Yeah, so I just wanted to share with you, we have offices around the world, and what we love to do is work together with people to build businesses around medical innovations. And to give you an idea of how we do that, I'll tell you the story of how we started a business ourselves together with John Kelly, an entrepreneur who wanted to improve the way we do point of care testing, and then mainly focusing on HIV testing. And we founded together Atomo Diagnostics, a startup. And in the beginning, it was only 5 people. We started in 2009. And we saw the opportunity where the industry, diagnostic companies, were competing around sensitivity and specificity in the lab of point of care tests for HIV. But then when we started to look at Africa, and we went to Africa and we did our desktop research, we found that the World Health Organization saw that in the field, even though these lab tests had a performance of 99.8% sensitivity or 99.9% specificity, in the field, 1 in 3 people with HIV went home thinking they didn't have HIV. And that was a staggering result. And also the reason why a lot of point of care testing were not deployed that much. So what we did is we went to Africa and we started observing what the problem really was. And we found that in the field, there was a lot of usability errors. So people were making mistakes, not putting the right amount of blood onto the strip, not on the right location, not using the right buffer fluid, not being able to read the result correctly. And we thought, as a startup, since these big companies are not doing it and they're designing these products for developed worlds, we can design something that's really cheap and affordable and accessible for Africa, and make sure that we remove these usability errors. So we did a lot of prototyping, building, testing, use studies in Africa, and we had to put it to the test because our initial products itself were not very successful either. We had to learn and test it. We also found that in order to be able to design something for Africa, it needed to be competitive. And most HIV test programs were purchasing products that were less than $1. So we wanted to develop a product that was user-friendly, no training required, but still we had to compete with products that were less than $1. So we used our network of manufacturers to supply products to us. And we found one partner who was very good at high volume production, low cost, but who needed us with our quality management system to access the medical market because they didn't have a medical qualification system. So we're now manufacturing under our quality management system, but with this supplier in China, we are getting very low cost parts in high volume. And then what we saw was that we got a lot of recognition from medical design industry, from design industry, from engineering, but also, for example, from the Bill and Melinda Gates Foundation, who identified that removing these usability errors and combining it with a design for Africa, low cost, would allow them to address this problem of not being able to test at the point of care or even self-testing. So to be able to give an HIV product to people and for them to test at home would really change the way people now get diagnosed for HIV. So it was really good to see that with a minimum viable product that we developed, we were able to get attention. And with that one, we were now able to develop the product further and create more user-friendly and even cheaper products. And at the moment, Tomo Diagnostics is now listed on the Australian Stock Exchange. And we're not only selling HIV products, but also malaria tests and COVID-19 tests. Some other products that we also developed include electronics as well. So what you see here in the picture is a cervical cancer screening device that uses optics. And this product was designed by IDE and is being manufactured by IDE. And it shows a lot of similarities in technology, so touchscreen housings. And that's the technology that we're also discussing now with Goal 3. So what we can see is that we would like to really join Goal 3 in this journey and together take the challenges of the system development, where Goal 3 clearly has all the expertise around clinicals aspects, the usability aspects, and IDE can bring the medical device experience and manufacturing experience. So we're really looking forward to join the Goal 3 journey and be a joint team. And yeah, I think that was something that we wanted to share with you as well, and extend the invitation to join forces and do this together. Thank you very much, Bart.
Yes, thank you very much. Pascal, let's go to the questions.
Yeah, thank you, Bart and Mes and Willem Mes. So we have some questions from the audience. We have a question from Alex Stevenson. He's asking, how hard would it be to link these monitors with an electronic health record?
So that's one of the things we are exploring ourselves as well. We believe that we will not be developing an electronic registered record ourselves, but we believe that we will join forces with someone who has already developed such a system. And we believe that there are already solutions out there, open source solutions, for example, for open source electronic health records, which we would like to connect to provide this as an additional feature.
Another question from Frank. He's asking, do you need tablets or could you also use smartphones?
So at this moment, we have built both a smartphone application which is focused on a single patient and a tablet application which is built for monitoring all of the patients at the same time, which you've seen a screenshot of. But I do believe that having an application for which can be used on any smartphone is a really good option. But there are also some regulation requirements which might be a problem when we want to create a medical device which needs to be certified. So we are definitely looking into it, but it's a bit of a challenge if we want to CE certify the whole product and a medical application on anybody's phone. So that's a challenge which we have not yet solved, but we are going to collaborate with experts like IDE Group and the medical software development group to tackle these issues.
Excellent. One last question before we can take a quick break. This question, I've been thinking about it myself. So when you arrived in Malawi with your device, what was the reception like? So what people think about your device, your technology, your solution?
That's a good question. So when I talk with a lot of engineers, nurses, and doctors there, the first question most of the people asked was, is it durable? Is it going to work in this environment? Is it going to, does it have a battery? Those were the first practical questions. And then the second round would be, are the sensors reusable? Are they available locally? Are we going to get them? And in the end also, is it affordable? And I was really happy that on all of these questions, I had somewhat of an answer. So we are able to, we are thinking along these lines, we've identified these problems and we're working on solving them. And especially, for example, for the multi-patient monitoring. So even in the PICU, which is really high end at this moment in Malawi, they don't have a central monitoring overview of their patients. And so, for example, with the tablet application right now, that's actually on their wish list for the PICU. And if we can provide this as well to even lower end wards, that would be a great improvement, which they would love.
That's really great to hear. Linking back to the presentation of Job, it's the user-centric design that he was saying that's lacking in the current monitors. So we shall now proceed to a short break. We will take a break of 5 minutes, and we'll be back with the next presentation. We are now halfway through this event. Thank you. Welcome back. Our next presentation is from Yele. Yele is the COO of Goal3. He's a young entrepreneur, and he studies Masters of Innovation in Management at Technical University of Eindhoven, and he has quite some experience participating in various social startups. So Yele is going to tell us about the business model and sustainability of this innovation that we have been discussing for the last 1 hour. Yele, the floor is yours.
Yes, thank you, Pascal. So up to, if you ask me, the most exciting part, a sustainable business model. How can we make something that is affordable on the short term, but also sustainable on the long term? So how can we make something that a hospital can afford now, but also can drive enough margins for us to keep making new products, keep innovating, and build a company out of this? So to start off, I would like to start with a question. What do these companies have in common? Bol.com, Tesla, and IKEA. I will help you answer it. They all have a very good product. They have a good technology, but what really sets them apart is that they have a revolutionary business model. So, to give a bit of insights in how we are designing a business model, because it's work in progress, we want to make it a bit more simple, so we start to look at the continent of Africa, but as you can imagine, our solutions can also make an impact in other parts of the world. And we dive a bit into problems that are occurring there, and I generalize a bit to make it more simple, but please know that countries across Africa differ a lot from each other. There's a lot of different people, a lot of different countries, a lot of different hospitals, a lot of different things. So, but there are some general problems that we can discuss. The main one is financing. So the financing in the healthcare system is a lot different than in Western settings, and often this also means that hospitals do not have big budgets to buy expensive medical equipment, and also in terms of salaries, in terms of medicines, in terms of supply chain, there's a lot of problems coming out of this financing streams. A second one is maintenance. As Bart already explained, products have to be durable, and maintenance need to occur, and this maintenance is really important for the products to keep functioning, because if the maintenance is lacking, products will end up somewhere like this. And this can happen even with products that are only 1 or 2 years old. And another reason this occurs is also that the supply chain is not always that advanced. So especially in rural Africa, if you have a hospital and you want to have a new sensor there, for example, a sensor breaks down and you want to replace it, it can take months or even years, or never reach even the hospital. So this supply chain issues is also something to take into account when designing a business model. And the fourth one, which is maybe a bit harder to understand, is the donation culture. So a lot of current medical systems are donated a lot of times, and these systems they break down a lot, and also they are not well understood, and if they're secondhand, they might be a bit too old. And this picture also sums some of the donation problems with it. So summarizing this, we have problems occurring across many hospitals in Africa, and if we zoom into these hospitals, we can see that there's around 5,000 hospitals that are big enough to apply patient monitoring systems across Africa. And in these hospitals, we can further categorize these hospitals. So that's what I will do now. So the first type of hospital is the private hospitals. And private hospitals are often highly financial stable. It's around the top 5%, so around 250, and they do have high quality systems. They also look similar to Western hospitals in some settings. But on the other side, we have rural hospitals, and rural hospitals are totally financially unstable. This is around 75% of all hospitals in Africa, and there's no high quality systems available, or if there is, they break down a lot, and the problems I mentioned occur a lot. And there's some category in between, which are urban hospitals, and urban hospitals are medium financially stable. They can pay up for some systems, and also this is around 20% of all hospitals, around 1,000, and there are some high quality systems already available. So if we would design a system, we would design firstly for an urban hospital, because these hospitals provide the clinical setting to test our system, but also the financial stability to roll out our system. But of course, we also want to be in these rural hospitals, because these rural hospitals is a place where we can think we can make even more impact. And also, of course, in private hospitals. So the vision behind this is that we bring patient monitoring, but also digital health and decision support applications. And we bring this together, and we're designing a new business model, and we call it monitoring as a service. And we're aiming to do this monitoring as a service with a fee of only $1 a day. And of course, it's wise to not already talk about numbers and prices of our systems, but this aim is for us really important, because if we can deliver this at $1 a day or somewhere close to this number, we can make monitoring equipment that was currently unavailable for hospitals, we can make it available for these hospitals. And we come at a new market where we can really make an impact with our system. So we bring them less admissions, short admission times, and especially a decrease in the mortality rate, which is of course the most important. So there's one quote describing why we are designing such a system at this way. If you do what everybody else does, you will get what everybody else gets. So we're really trying to make a new business model that can really revolutionize this whole market and not do what everybody else does. So walking through the numbers, in the first years, we will start in our first phase, and it's a proof of business phase. In this phase, we try to apply our systems in 10 hospitals with a $1 a day fee. And these hospitals are possibly in an area close to each other, so we can have quick learnings and really implement and test the system together with the user. If we see that this is working, we come to a scaling up phase where we can also go to other countries and scale up our system, where we want to grow our business to 5,000 systems in 200 hospitals. And by this point, we also make a break even, so we can say that we earn more money with our patient monitoring system than we have costs as a company. And this is really important for us. And this sets us on our way to a third phase where we can broaden our products, so we can also look more into algorithms, software, other types of support that we can give to a hospital to make them work more efficient and more effective. So, but these numbers are all interesting, but what we're really doing and what is really important for us is that we are monitoring directly 5,000 patients a year already in the coming 3 years, and that we can grow this to 250,000 patients in the coming 7 years. And this is a yearly monitoring, so this can make a real impact on many lives. So the last question you might have, how do we get there? Of course, we know that we have to start somewhere. So starting somewhere, we're really trying to make a sustainable business case with an African office delivering healthcare services. And this office has to be sustainable so that it can service around 10 hospitals in the neighborhood with our systems, but also with our service, support, and maintenance. And if we can make this sustainable, we can show the world and we can show African entrepreneurs that this model can be duplicated and we can empower entrepreneurs together with financing and also with customers throughout the whole continent. And we can make small goal-free offices all around the continent, or even do it together with partners. This creates a scalable commercial rollout, many new African-led businesses, and most importantly, serious improvements in the healthcare system. So there was a lot of information. I want to summarize it for you. We see some problems in the market, and we really have to think about these problems when designing a business model. We have various types of hospitals, and we have to take them into account. We want to bring a revolutionary new business model to the market, aiming at offering our services for $1 a day. And this makes us break even somewhere in 2026, 2027 with 200 hospitals. And we do this in a very scalable way. And what this does is that it brings us together on our mission of improving the access to care for 100 million people by 2030. So that's what it's all about, and I would love to hear your questions.
Thank you, Jelle. It's an exciting presentation and lots of exciting numbers as well. But I can imagine now in the audience there may be some people who are wondering, like, if I want to have this technology, this monitor in my healthcare facility, how do I get it? Where can I place an order, or like, can you tell us a little bit about that?
Yes, so it's very important to understand that we're still in development, so it's not that people can now go to a website and already order. But what we want to do is, in the first years, we want to do it really together with the customer. So we want to be really close to a customer. So in the first years, we would try to have one country or one group of countries where we specifically test our systems. And if we can really show that this works, then customers can to us, or we can go to customers, and we can roll out this business. So we don't have a specific channel yet, but this will come in the future.
This is very good. So from now until the time when the product will be readily available on the market, what do you see as the main challenges or the main steps that you'll have to take to make sure that you are actually there on the time that you have you just showed us in your timeline?
Yes, so there is on one side the technical aspect. So we have to make a technically well-functioning product, and this product has to be innovative enough and effective enough to really make a difference in. But it can also be small enough to make sure that we can go to market as quick as possible. And if we can make this product, we can also fine-tune our business model together with a hospital, so we can make sure that we have a fee that can be paid, and that this fee also acts as a fee for ownership, that a hospital is really actively working with the system and really showing that it works, and really trying to get the maintenance and support needed for the system. So in steps, first we have to technically go a bit further, and then we have to find the right entry market where we can test also commercially our systems. And after that we can hopefully roll out to the rest of the world.
I hope there will be a way that participants in the audience can stay in touch with you to make sure that they don't miss out any of these important steps. I would like to remind you in the audience that you can always ask questions. I can see some questions that are coming in that were meant for previous speakers. No problem, anytime a question pops up in your mind, you can always send it to us. We'll go through them even after the event, so we can make sure that you have the right answers. But now, if you have questions related to this business model that we just heard from Jelle, please feel free. If I may ask you another question, you described two phases. So you will start with a small number of patients, monitoring a small number of patients in the next 3 years. And after that, you will scale to 250,000. So from 5,000 to 250,000 in 4 years. Practically, how do you plan to scale that fast? It would be nice really to hear that component, especially for any potential investors or anyone who is interested really in your actual figures. So please tell us about that.
Yes, that's a good question. So if I present these numbers to some people, there's also people saying you're not scaling fast enough. So it might be a matter of perspective, but there's a few things. So one of them is really trying to show our model of sustainable healthcare maintenance support service and delivering this. So as I showed in the map, if you can really show that this works, then it might be possible that you can open up 2, 3, or 4 new channels and new countries every year. And this will also open up new hospitals. But what also might be the case is that when we successfully show that what we do works, this will also attract governments, ministries of health, but also possible partners that really want to work with us to do this scale up. So for us, it's really if we can show the proof that it works, that it's sustainable, and that it's viable and feasible, then we believe that this scale up can go really fast with the right partners.
Yeah, indeed. Talking of partnerships, we already saw in the previous presentations that you are already building quite some powerful partnerships here in the Netherlands, in Africa, in Malawi, and you just did this in 1 year. And you're talking only of a prototype. And indeed, if you have something that works that you can show to even much bigger partners, I don't think that it will be a challenge to reach these numbers. So we have a question from the audience, question coming from Alan Weaver. The question goes like this: would the system be tailored for specific types of hospitals, and how would the system be expanded to include other hospitals, considering the limitations that these hospitals might have?
Yes, so there's a big part of the system that is can be used in many cases. So the interface, the sensors, etc. And there's a small part that would be specific to a hospital. It could be, for example, a payment integration with a local payment service, and it could also be e-health integrations with patient records, or even communicating in their own language. It could also be possible. So what we really try to do is make a scalable system that can work kind of plug and play, so that if you want to start up in a different type of hospital in a different type of country, you can just only have to adjust these 10% of the system, or maybe even 5%, and make it work there as well. And we are luckily in a market where a lot of hospitals buy not one system but 10 systems, so it is often also profitable to make this system a bit more tailored to their needs.
Very good. So we have another question from Cole Kalkman. So he's asking, do you propose to offer the service and hardware on a loan, like a subscription model, or can you tell us more about that?
The specifics would be also kind of depending on the situation, the country, and the manufacturing price that we can get our systems to. So the first thoughts are to have a leasing model, but after a few years the system becomes by ownership of the hospital if they work with it correctly. And if it's not functioning in the hospital, we will of course find ways to make it function or to see how we can make something that function in the hospital. But we could also say, okay, it's not functioning, so for us it's no use to have our system there, and for you it's not no use. So then we could also get it back. So that's also why the leasing model is there. But we want to have the systems in place in hospitals. So if they are functioning over a long period of time, we will make sure that they stay there.
Thank you. Thank you very much. I think these are all the questions we have from the audience, but I'm sure there will be more coming. So just be ready to answer them
Yes.
anytime. So now we shall move to the next presentation. And this presentation is will be done by Kevin. Kevin is the CFO of Goal3. And Kevin has worked for Ernst & Young, and he's an experienced finance professional with over 10 years of experience. And he has been working in various senior roles. Kevin, welcome. And so you are going to tell us about what Goal3 has achieved in this past year that has been active. So please, the floor is yours. Thank you.
Thank you, Pascal. Well, I will show you something about the financials. But before I do that, we had some great presentations already, but the best is still to come. So let me take you through. So let me take you through the financials. But before I do that, I would like to go through what we already achieved last year. And the best way to do that is do that with a video. So I would like to start a video right now.
In the category prototyping is Goal3. Congratulations.
Goal3!
The winner is Jelle from Goal3.
Yeah!
Please join our mission, because we all help.
So for me, the best part was the cheering, of course. And just switching to my slides, just a moment, please. So, in the video you saw us win 2 awards, the TU contest and the Everest Award. And next to that we also participated with the Health Holland Venture Challenge. And what you did not see in the video is that we also was awarded 2 grants, the Takeoff Grant and the MIT Visibility Grant. And with those 2 grants we were able to send Bart to Malawi. So we've been here for the last 2 weeks, and he will go there in January to test our first prototype, and also he will do our feasibility study. Next to these awards and grants, we are in the middle of other awards and grants that are still running as today. If you look at the awards, we are in the final 3 of the Building Better Future for Health Award, which is organized by IDE Australia. And we are in the final of the Everest Award, which will be finalized this evening. So I hope Nick will have good news this evening and say we will won the prize of 60,000 euros. But we'll have to see. Another thing we are in the running for is the Chamber of Commerce Innovation Top 100. And we're in the running for Best Tech ID for the Kijk magazine. Also, we are still running for 4 grants, which will I get back on later on in my presentation. So another achievement I want to mention is our partnerships, because we think to reach our goal, we have to build partnerships that are solid and durable. And Bart already mentioned a few of the partnerships. I've taken an overview of these partnerships. For the first, the takeoff pilot study in Malawi I already mentioned. And the second is the Impala Research Consortium, where we will build our patient monitoring system, and the patient monitoring system will develop towards an MVP. And the last one is the pilot study for the algorithm we will perform in March and April of this year. So next to these partnerships, we have also found ourselves qualified partners in other areas like technical development partners. Well, you already heard IDE. We have a few other technical partners for other components. And also on the business strategy, and we have also found 2 partners, which at the end of the day, you will hear Chris van Vunt. Another achievement we already realized is our team. So starting with 4 at the beginning in 2019, we are now with 10 team members. Well, I'm on the left side of the picture. You've all seen Nick, Bart, and Jelle. Well, there are 6 others who are behind the screens and would like to go through. From left to right, we have Rachel, who is a product developer and responsible for the quality management system. We have Annelot, who is responsible for HR and communications, and also organized this event. Thank you, Annelot. We have Jori, who is responsible for our graphic design. We have Balt, who is an experienced entrepreneur in the African market. We have Thijs, who is our embedded system engineer. And we have Martin, but he's not on the picture, as Nick already told. He's our front and back end developer. So looking back, how did we achieve all this? Well, it's quite simple. We achieved this. So let me go back. We achieved this by bootstrapping our company, which actually means we didn't need any outside investment. Just to have a quick view, we invested 50,000 euros by the team members. We had some grants, and we have awards, and that's how we bootstrapped up until today. But what's next is we all know that bootstrapping isn't the way forward. If you keep in mind our goal to improve access to care for 100 million people by 2030, we know that bootstrapping isn't the way to go forward. So if you summarize it, we calculated our investment needs to approximately $7 million to euros, to go to break even in 2026. If I split up these investments, then we have identified 3 rounds. The first round will take us to developing our prototype 2. The second round will make us to an MVP and to get to the market. And the third round would enable us to sell our product in the market and get to the break-even point. So let's go into our first round, which will be a crowdfunding round. And although we mentioned 750K, we have a minimal and optimum scenario. And in the minimal scenario, we would be able to produce our prototype 2, perform a pilot study, develop have our product development plan, and produce 50 monitor system to implement in an African country. We also were able to do our first pilot study on algorithm. We are able to extend our market field research, and also we are able to do our basics in QMS and ISO preparation. And if we would get to 750K, we are able to speed up the process, maybe even get to prototype 3 at the end, extend our work on algorithm and market field research. We aim to have our first local representative, and also we're able to set up additional partnerships, what we believe is the best way to go forward. So something about our crowdfunding round: it will start in December and will run for a month. We'll do that in a convertible loan or convertible bond, which, for those who are not familiar with convertible bonds, it's a preface of being a shareholder of Goal3. And we'll do that with our partner Symbit, which is a professional platform for crowdfunding. So next to this external funding, we also have the opportunities, other opportunities to fund our business. One is the in-kind contribution. Well, Nick already told that in the first year we did a lot of in-kind contribution to get to where we are now. We're able to do that this year as well. We all know that it's not a strategy for the long run, but it gives us some flexibility in expenses. The other one, and maybe even the bigger one, is the non-dilutive. We are in a position to apply for many grants, and as already told, we have 4 grants running right now. Just to have an overview of those 4 grants, the biggest one is EDCTP, Bart already mentioned. And the other grants also have components of our patient monitoring system which we need to develop. And next to these, we are exploring other grants, and we will assess them in this coming months. So at the beginning, I told you the best phase is still to come. I would like to give the screen to Chris, and Chris will take you to the healthcare innovations in Africa. Chris, the floor is yours.
Yes, thank you, Kevin. First of all, I would like to thank everybody here present, and also thank Goal3 for the opportunity to share Fund's vision and how we are working together with Goal3 to realize their goals. So give me 1 second, I will start sharing my screen. Can everybody see my screen? I believe so. Okay, so first of all, I will give a brief introduction of myself. My name is Chris Kohler, partner at Fund, a consulting firm in the Netherlands, originally from Togo, West Africa. So, and I think that's also one of the main reasons why I fell in love with Goal3. And the first time that I met Nick, it was in our offices in Apkoude. And I think right away, we understood that a collaboration between Fund and Goal3 would have to be rooted, and is rooted, in a shared value that we have, is that we have a passion to solve societal problems through innovation. At Fund, we do that in the Netherlands, clearly throughout Europe. However, with Goal3, we are making our first steps to expand our reach and really help create innovations on the African continent. Next to being a partner at Fund, I am also finalizing my MBA at the Erasmus Rotterdam School of Management. And I've just did a research on the barriers to healthcare innovations on the African continent. And I would like to take you through several of my results that I have found, and also again highlight why Goal 3 is developing an innovation that is very timely for the African continent. So one of the main things that is happening on the African continent currently is that the population is about to double. Between now and 2050, the continent's about to grow with 99%. So go from 1.3 billion people today to 2.5 billion in 2050. Compared to Western countries, the growth there is about 2%. So the continent is about to explode. Obviously, this will have several pros and cons. So first, let's go over the pros. Africa will have the largest population of working age by that time, by 2050. 1.1 billion people will be of working age. This means that it will be a great engine for production, for job creation, and hopefully to reduce poverty rates across the continent. Thirdly, this will lead to the fastest GDP growth region in the world, where you will have yearly GDP growth of 10 to 15% depending on the country. So the continent is really set to grow rapidly. However, this will come with several healthcare challenges, mainly a demographic shift. So we will see about 322 million children being added to the population, about 93 million elderly people being added to the population. And when we think about neonatal care and the importance of neonatal care, these figures highlight that. It will become very important in the coming decades on the African continent. Urbanization will rise, and this will lead, unfortunately, to a proliferation of slums. About 60% of the future population is projected to live in slums. And this will inevitably lead to an increased incidence of communicable and non-communicable diseases, appearances of new lifestyle diseases such as diabetes, heart disease, but an increased need for neonatal and elderly care. And that's where Goal 3 comes in. So during my research, I focused on really looking at the innovation landscape on the African continent through a conceptual model, which is based on system thinking and looking at the several pillars that have to be in place in order to make innovation work in a country. The first one being the supply of innovation, the linking mechanisms, and demand for innovation. So what I did is that I did qualitative research in Benin, Mozambique, and South Africa to identify what those barriers to innovation were in those countries. And the results were pretty interesting. So first, looking at the supply of innovation, what we see is that it is very difficult to innovate in African countries due to several factors. First, if we look at countries such as Benin and Mozambique, which have lower population rates and lower GDP growth per year, you see that the right policies are not in place to support innovation. You see that innovation strategies are not in place. Higher education institutions are not well equipped in order to create innovations. And going all the way down to public R&D funding is missing, and the rate of qualified scientists, engineers, and technicians is pretty low. If you look at that figure, the UN calculates that a country needs about at least 23 qualified scientists, engineers, and technicians per 10,000 people in a country to be efficient and to be able to innovate. If you look at the Western countries, that amount is about 58. However, in African countries, the average is seven. And in some countries, it's even 2, such as Togo, the country where I'm from, right? But if you look at those figures in South Africa, for instance, it's a bit more nuanced, where you see that policy in South Africa is a bit better. Higher education institutions are a bit better. However, you see that there's still a lack of good infrastructure there in order to make innovation happen. If we go to the linking mechanisms, which are the mechanisms that link innovation supply and innovation demand together, we also see quite some interesting things. We see, for instance, that the ICT infrastructure in most countries is lacking, and which is basically acting as a barrier for innovations to take place and take root. Seed capital is missing, and also mobility and of people and expertise is also hampered due to vast areas and also some bad roads and bad infrastructures that do not allow people to work and move freely. And finally, if we go to the demand for innovation, we see that the countries usually in this sector miss a competitive domestic market and also do not have the clear access to international markets. And end users are not taken along in the innovation pipeline and innovation trajectory. So these are the main results that we see. However, what I did is that I tried to look at Goal 3 from this lens. And what do we see? We see that Goal 3 is well positioned to actually tackle most of these barriers that are hampering innovation on the African continent. For instance, Goal 3 is making use of the policy infrastructure and the innovation strategies that are set in the Netherlands in order to kickstart their innovation. Jelle, being from the TU Eindhoven, is making use of that infrastructure, the higher education infrastructure, to feed into Goal 3. Business education is also being supported. Fund is also supporting Goal 3 in that. Public R&D funding, as Kevin was just saying, is secured through non-dilutive funding, access to qualified scientists, engineers. So Goal 3 is really ticking all of the boxes on the supply of innovation side. If we're looking at the linking mechanisms, also collaboration is being set up in the countries themselves. And I really liked what the previous presenters were saying, Jelle, I believe, and it was really to empower the local entrepreneurs and also to create African-led businesses. And Goal 3 is hitting that mark also. Looking at the presentation of Kevin, we see that seed capital is being planned in advance and is going to be secured. Mobility of people and expertise, Goal 3 through BART is being on the going to the continent and is present physically. And finally, access to international markets. It's clearly in the plans of Goal 3 to expand. And finally, the end users are also being taken along during this whole pipeline. So what does this tell us is, one, that Goal 3's innovation and idea and actions on the African continent are timely and cannot be even, I cannot stress how timely this is. The neonatal care on the African continent is about to require a lot of support, and I think that Goal 3 through their innovation is ready to provide that support. If we look at how Goal 3 is able to tackle the innovation barriers on the African continent, they're also well positioned to tackle those. So I think it is a matter of time before the goals of Goal 3 are materialized on the African continent. Now, to close the loop and to come back to Fund, how are we supporting Goal 3? Well, basically, we are helping Goal 3 to move from idea to market. Creating an innovation and also putting that innovation in the market is like going through a maze. You do not know, you know that you have to go in a direction, however, you do not know what is coming on your way. So through our strategic collaboration, what we do is that we help Goal 3 with strategic business advice. We help the management of Goal 3 and the entire team, and we collaborate pretty closely. We help Goal 3 set up the finance strategy development. And finally, we help Goal 3 secure access to finance support through grant writing support, and also in the future to securing dilutive funding. And on this road with Goal 3, I am very, very proud, coming from Africa myself, to be on this journey.
Thank you, Chris. Thank you for painting this macroeconomic picture of what's happening in Africa in terms of innovation. And also telling us how Goal 3 is positioned, in your opinion, also based on your experience, not only as an African, but also as a professional here in the Netherlands, on how Goal 3 can help solve some of the big problems we are experiencing today in Africa.
Yes.
For the sake of time, I will only ask you one question. You showed us in your presentation all these achievements that the Goal 3 has accomplished in just 1 year. So this kind of momentum that you have already built, how do you plan to maintain it in the coming, let's say, coming months, coming years, to make sure that all these developments, these partners like FUND, the Amsterdam Medical Center, IDE, all these other partners, you keep them, but also you keep even building, attracting even other partnerships. So how will you maintain that?
In doing that the last year. The way we maintain that is constantly looking for partnerships and also looking for a project where we can strengthen each other. I think that's for FUND. Well, Chris already mentioned there's a lot of connection, but also with other partners there's a lot of connection. And even now we are exploring other partnerships for different parts of our development, like the algorithm, to go to another partnership with new grant applications and new projects. So it's a constant, continuous process, and which I have to say Nick is very active in. He already is in the medical scene, so he knows a lot of connections, and he has a lot of inside experience in the business. So.
Thank you, Kevin. I can't wait to see where Goal 3 will be in the next 3-5 years. Thank you.
Thank you, Pascal.
So we're approaching the end of this event, but we shall. I will invite again the CEO to come join us again and help us conclude the event. We still have some questions to ask him, like what. The ways forward. So what will happen after this event? But before we get there, I hear, Nick, you have a very exciting video you like to watch maybe every day or every week?
Well, I don't have it for that long yet, but I could watch it every day, I suppose. Now, at the start of the thinking about this event, or actually during the process, we're thinking, what is it all about? And that was a question I asked myself, and then I had to think back to Tanzanique, the boy we've seen in the picture. And I'm actually still in contact with his mother. We send text messages every month, and I asked her, can you make a video maybe? And I was like, okay, maybe some raw footage just with a camera. And she actually hired a cameraman to make a video, and that is something that means a lot to me and I like to share.
Yeah, please, let's watch that video. So, Nick, you know this boy when he was a baby. Today he's quite a very healthy child. We can see him playing with his friends, going to school. knowing the conditions, the circumstances of his birth, and seeing him today in this video, what does that mean to you? How does that make you feel?
Actually, I'm really happy. I really had tears of joy right at this moment when I was looking at this. And for me, this is what it means to make an impact. And I already explained during my introduction what it meant for me at that time. But actually, the meaning of it even got bigger. So the last shot you see is actually my son who's playing with this boy in 2017. My son was 1 year and he was 2 years, and actually that's when it really felt like a parent what it means when a child survives. And to see this now, and he's a similar age to my son, it's like, that's just amazing. And I think that's what we're doing it for, because we're addressing a huge problem, but we don't want it to be a heavy journey. We don't want to talk about dying children. We don't want it to be a depressive story. It's a positive story. And these are the stories we need to tell and need to amplify, and to make sure that they become larger and they become more of them. And I think that is what we want to achieve as Goal 3.
That's powerful, especially coming from a father, but also a medical doctor. So this is a story of one boy in Tanzania, but you are building Goal 3 to bring such success stories to scale, to hundreds, millions of children all over the world. What do you think is the key ingredient for Goal 3 to really achieve this goal? Like, how do you see the future of Goal 3? What steps will need to be taken to reach that future you're painting?
So it's kind of, I like to the way I see the vision. So we have been talking about really one product in one area, and what people may not realize is that there are a lot of applications for that, and a lot of different things we can still develop for this. So we're talking about now predicting sepsis, but you can help with discharge, you can help with admission. There are a lot of other things we can, and you can do it for children in different settings, in the emergency room, you can do it in theater. There's really a lot of ways. And actually the core of the system, so the hardware that Bart presented with the application, it's actually quite universal. And it's about the content that is on there that you can use. And I like to compare it myself to Spotify. 10 years ago, nobody would have imagined that for 10 euros a month you could have access to this amazing library of music from all over the world. And what I would like to see is that as Goal 3, we create a library of software and algorithm applications that can really improve the lives of people, and we generate it together with our partners. We create it, and in a way, I like to see our partners, the Radboud, the Amsterdam Medical Center, all these partners. I like to see them as the musicians who make the content of our platform. So in 3 or 5 years from now, everybody for a fixed fee model can have access to an amazing content and that improves the lives of people all over the world. And I think that is also where it starts. If you want to go far, go together. So we really need to collaborate this.
Yeah, as we conclude this event, as the CEO of Goal 3, what is the key message you want people or participants or anyone who will watch this event later to? What's the key take-home message? And what will be the call to action?
Good question again. Well, I think it's also from my presentation. It's time for change. There's, to me, all these people dying from these conditions, which are easily treatable, it feels like an open wound, and it's time for change. And we can do it if we work together, if we collaborate. We can really make it happen. And of course, we're not here to tell you we have all the answers yet. We're not there. We're at the start of a journey, and it was mentioned a few times. It's start of a journey, and I think everybody can on board on this. And that starts with people. So we'll be needing a lot of things, but it will only come to us through people. So we need people who believe in this dream and who are willing and able to bring us there. And we'll see what challenges we'll face along the road, but we're there to face them, and we'll just do it.
Thank you. This is pretty exciting. So we're approaching the end of this event, but for the very last practicalities, I would like to invite Anne-Lotte. Anne-Lotte is also in the team of Goal 3, and she's the actual brain behind this event. Anne-Lotte, congratulations. I think it has been quite a successful event. Great work you've done.
Thank you. Well, compliments to you. You did very good moderating the event, and I'd really like to thank you a lot for all your help and for being here today with us.
Thank you. Thank you. So what is your general impression of this event? What do you think? Do you think you have achieved the objectives you had when you started thinking about this liftoff event?
Yeah, I think so. I think with the recent restrictions due to COVID-19, we had to find a good solution to actually try to connect with others and to be together in a new kind of way. And I think with this event, we've actually really collaborated with a few partners and really discussed the topics we want to get out of this out to the world. And now we can move on from here and hopefully create lots of really special collaborations.
Yeah, for the audience, but also for anyone who would like to watch to rewatch this event, or someone who did not make it to the specific schedule of today, is there like any? Are you going to share the presentations? Can you tell us about any practicalities?
Yeah, of course. So everyone who registered on Eventbrite will get an overview of the event after, as soon as possible. I will go work very hard on that. And also all questions have been received, and we will follow up on the questions that were asked and we didn't have time to discuss during the event. And we will post on LinkedIn, of course, and on our website. So we will have everyone greatly connected, hopefully. And if before we put the information out there, people would like to reach out, you're more than welcome to contact us via LinkedIn or our website. And yeah.
Thank you. Thank you.
Thank you very much.
And all the best with the next steps.
Thank you too.
Yeah. Thank you to everybody who has been with us for the last 2 hours. This marks the end of today's event. Thank you. Thank you so much.